Good afternoon, everyone. Welcome to the last session of the California HPV Vaccination Learning Collaborative, brought to you by the California HPV Vaccination Roundtable. My name is Shante Davis Patterson, and I am the Program Director for California's Comprehensive Cancer Control Program under the California Department of Public Health, and we administer the State Cancer Coalition, the California Dialogue on Cancer, or CDOC, which is co-founder and coordinator for the California HPV Vaccination Learning Collaborative. We're very happy for you to be with us today. So just a little bit of housekeeping. Everyone has been muted, but you can ask questions in the chat box, and we will have time at the end for questions as well. This is being recorded. And I do want to make a note that we are working with some glitches on our website right now, the Learning Collaborative piece on the California HPV Vaccination Roundtable. So be patient with us, but we'll have that up and running soon. And then we also have an evaluation at the end. So for an icebreaker today, we all know it's too many folks to get on and introduce yourself. So in the chat, if you could tell us your name, your organization, your role, and your favorite fall activity, because the weather is starting to turn after a heat wave that we've all been experiencing through October. Can't believe it. But I know I'm here in Sacramento this morning and it actually kind of looks like fall. So let us know what your favorite fall activity is. So this learning opportunity is being brought to you by the Engaging Health Systems and Providers Work Group of the California HPV Vaccination Roundtable. And what is the Roundtable? We are a coalition of diverse stakeholders with a mission to work together to prevent HPV-associated cancers and precancers by increasing the California HPV vaccination rate to 80% by 2026. And there's our website. So our agenda today, we're going to hear just a couple of roundtable updates, and then we'll jump right into our main presentation, Building Confidence in HPV Vaccination and Combating Hesitancy and Myths. And then we'll have question and answer, and we'll close. So as I always announce every session, we are coordinators for the Announcement Approach Training. The Announcement Approach Training presents strategies for recommending the HPV vaccine to promote vaccine acceptance and save clinical time. It's designed for providers interacting with parents. You can learn the latest on HPV vaccine research and guidelines, as well as brief evidence-based communication. And it is a 1 hour interactive training, and it's online. So contact us to schedule a training if you and your colleagues, your health system would like us to do a free announcement approach training for you. And we have been trying to get a continuing medical education units for this training for a while, and we're still continuing to pursue those. So once those are available, we will let everyone know. I also wanted to just kind of direct everyone to our HPV Vaccine Week website. Now, HPV Vaccine Week occurs every the first week of August of every month. And we had a successful HPV Vaccine Week this year. But I just wanted to remind everyone that all of the assets and everything that's been developed for HPV Vaccine Week is still available. And it can be used at any time of the year. So just wanted to let you know that all of those assets and all of those resources are still available on our website. And you see our website there. Right. Okay, so now it is my pleasure to introduce to you our guest speaker today. Dr. Melanie Kornides is an associate professor of nursing at the University of Pennsylvania School of Nursing, specializing in adolescent health and vaccination behavior. Her research primarily focuses on understanding and countering health-related misinformation online, with a significant emphasis on the HPV vaccine. Over the past year, Dr. Kornides has led several projects aimed at developing interventions to combat HPV vaccine hesitancy and misinformation, leveraging theories like inoculation theory to enhance vaccine uptake among adolescents. Her collaborative work extends to nationwide surveys and developing augmented reality tools for health promotion. A recognized leader in the field, Dr. Kornides brings a wealth of knowledge on effective communication strategies to address vaccine hesitancy among parents and guardians in clinical settings. And we are very, very grateful to have her present for us today. So I will turn it over now to Melanie Kornides. Thank you.
Thank you so much. I'm so happy to be here today to talk to you about addressing misinformation. I have put together a talk that is a little bit about my own research, but then also pulls in what we currently know about vaccine misinformation from various studies that have been done in the past few years. So hopefully it will be a good update for you on what is most recent in combating misinformation. Do you want to pull up yeah, perfect. You can go to the next slide. So I just want to disclose that I am funded in part by a grant from the National Cancer Institute, but I have no other funding disclosures. Next slide. So as you know, HPV vaccine is a critical tool for preventing certain types of cancer. But despite this, our vaccination rates are often hindered by misinformation, which can lead to hesitancy among parents. So today I'm going to tell you a little bit about me and my background, and then we're going to sort of go over what we currently know about the answers to 4 questions. What do we know about HPV vaccine misinformation and misinformation in general? And what do we know about its impact on vaccine acceptance? What are some evidence-based strategies to address misinformation? And then briefly, we'll talk about what don't we know, what is lacking still in the field. And then at the end, we can take time for questions. So I'm an epidemiologist and a nurse scientist in the Department of Family and Community Health at the University of Pennsylvania School of Nursing. The main focus of my work over the past 8 years has been vaccine hesitancy, mainly HPV vaccine. Next slide. So my approach to studying vaccine hesitancy is through a combined lens of both epidemiology or population health research as well as a nursing lens. My research interests come out of 10 years of primary care practice as a family nurse practitioner in various community health settings, a federally qualified health center in Los Angeles, a free clinic for adolescents outside of Washington, D.C., and a teen pregnancy program in Arlington, Virginia. Next slide. I became interested in vaccine hesitancy when I was doing my postdoc training. I had a fellowship in pediatric health services research where I worked predominantly on HPV vaccine communication with my mentor, Melissa Gilkey. And my research has sought since then to understand and intervene on vaccine hesitancy, particularly hesitancy related to misinformation. Next slide. So moving on to our first question, what do we currently know about vaccine misinformation? So we can define misinformation within an online or social media environment as the inadvertent spread of false or incomplete beliefs without the intent to cause harm. You can contrast this to disinformation, which is false or incomplete information that has been created and shared with intentional deception on the part of an industry or organization, usually for financial gain. So many anti-vaxxer organizations are spreading disinformation that is then picked up and spread by well-intentioned people. And so at that point, it becomes misinformation. We've had a lot of studies that have shown a high prevalence and widespread dissemination of misinformation about vaccine side effects. We know that prior to the pandemic, an estimated 41% of parents reported having been exposed to misinformation about vaccines on social media forums. So in this picture here, this is an example of the type of misinformation that you might frequently encounter on social media. This is a Twitter post, or I guess it's X now, from March 19th of last year, stating that the HPV vaccine does not decrease cancer incidence and has dangerous side effects. This organization that posted it is the AFLDS, Americans Frontline Doctors, and they are actually a prominent anti-vaxxer group that masquerades under the guise of a physician's advocacy group. Next. So then these are some responses to that Twitter post, and I chose two randomly. The first response responder states that she refuses the vaccine for her children despite being pushed by the school. She states that knowledge is key and critical thinking is necessary. And then the second response falsely states that the FDA approved the vaccine despite safety studies showing that it had a death rate 37 times that of cervical cancer itself. So you can see how posts like this would be very concerning to parents. Next slide. This is from a few days ago, and these are frequently searched terms on Google for the HPV vaccine. And you can see a lot of these questions contain misinformation. Why is the HPV vaccine not popular? What are the neurological side effects of HPV vaccine? What is the Catholic Church stance on HPV vaccine, which is suggesting that it is linked with sexual behavior. All right, next slide. So in my own work prior to the pandemic, we found a considerable amount of negative information about the HPV vaccine circulating on social media. About a quarter of all of the posts related to HPV in general, not just vaccines, was specifically misinformation about the HPV vaccine. And what we found was that health-related misinformation was the most prevalent type of misinformation that was frequently occurring and had the highest levels of audience engagement, meaning people responded, they liked, they retweeted much more often than other types of posts. Next. So this vaccine misinformation, HPV vaccine misinformation, has increased significantly since the pandemic, especially through social media platforms like Facebook and Instagram. And it's often alongside broader anti-vaccine content related to COVID-19. Studies estimate that between 6 to 8% of people exposed to vaccine misinformation on social media experience a direct reduction in intent to vaccinate. And adolescents and their parents are key targets for HPV vaccine-specific misinformation. A 2021 report by the Center for Countering Digital Hate attributed 65% of all vaccine misinformation posts or content on social media to just 12 individuals or 12 organizations. And this is impacting various vaccines, including the HPV vaccine. So you can see where the disinformation franchise sort of churns it out and then it gets spread around after that. So how does all this misinformation affect vaccine acceptance or vaccine behavior? When we think about vaccine acceptance, there are two components. We have vaccine confidence and vaccine hesitancy. Vaccine confidence refers to the trust that individuals, parents, and communities have in vaccines, the providers who administer them, and the systems that develop, regulate, and promote their use. Whereas vaccine hesitancy is a delay in the acceptance or an outright refusal of vaccines despite availability of vaccination services. And this can be on a spectrum of mild to severe vaccine hesitancy. So some key differences between vaccine confidence and vaccine hesitancy. Vaccine confidence reflects trust in vaccines and the vaccination system, leading to proactive vaccine acceptance, whereas hesitancy reflects doubts or uncertainty about vaccines, leading to refusals or delays despite vaccine availability. So in other words, vaccine confidence promotes acceptance and vaccine hesitancy essentially promotes refusal or delay. Prior to, I think that's it for that slide. Yeah, we can move on. So high vaccine confidence is associated with higher rates of vaccine uptake and fewer delays in vaccination, whereas low vaccine confidence is associated with higher rates of refusal and delay. There are three C's when we think about vaccine hesitancy. So you can think about vaccine confidence as an attitude or belief, and vaccine hesitancy as a behavior. And these three C's are complacency, convenience, and confidence. So vaccine hesitant individuals may have concerns about the safety or necessity of vaccines, or they may mistrust the healthcare system, but they're not necessarily opposed to vaccines entirely. You can see here, this is a picture from the UK protesting against the HPV vaccine and flu vaccines, and it displays the effects of misinformation. And we know that vaccine hesitancy has been a challenge for healthcare providers long before the COVID-19 pandemic, and it's only been recently, it's just been amplified by the sort of deluge of misinformation that's come out about vaccines. Globally, multiple studies have found that social media dynamics exacerbate the sharing of misinformation and reduce vaccination rates, undermines trust and reliable information, increases polarization, and damages the credibility of institutions or the perceived credibility. So for example, in a 2018 national survey, almost half of the parents, 45%, reported hearing personal stories about harm of HPV vaccine. And those parents who heard personal stories had higher odds of delaying or refusing HPV vaccine. A 2021 randomized control trial also demonstrated that misinformation exposure on social media lowered individuals' intent to vaccinate, even among those who initially stated that they were willing to vaccinate. And this underscores the power of misinformation. Next slide. Misinformation often spreads because it plays on emotional concerns, mistrust in authorities, and the influence of peers. So, for example, mothers engaged with anti-vaccine social media content were more likely to delay or avoid HPV vaccination in this 2021 study. This highlights the importance of addressing the psychological factors driving hesitancy. So next, let's talk about a little sidebar of why this matters. And I'm guessing based on the audience that most of you know this, but HPV vaccine rates are not as high as other adolescent vaccine rates. So next slide. Not only are we not meeting our goals nationally, but we're also just not even matching what is getting into adolescents otherwise. So Tdap vaccine outpaces HPV vaccination. So adolescents are getting the opportunity to be vaccinated, but for whatever reason, not always taking it. So in the US, our one-dose completion rate is fairly high. It's 79%, which is great. We have a goal of 80%. Then our two-dose completion is lower, it's 61%. And again, we'd like to be 80% or larger. And there are disparities based on the region and the socioeconomic status. In comparison, 90% of adolescents nationwide have received the Tdap vaccine, which is typically required for school, and HPV vaccine is not. Next slide. In California, we see higher vaccination rates compared to the national average, so you guys are doing well, with 86, almost 87% of adolescents receiving at least one dose and about 70% completing the series. And these numbers are encouraging, but there's still room for improvement because similar to the national average, over 90% of California teens have gotten the Tdap vaccine. Next. And then according to the most recent NIS teen data, about 81% of girls aged 13 to 17 received at least one dose of the HPV vaccine, compared with 77% of boys. And then when it comes to completing the two-dose series nationally, 63% of girls have completed, while only 59, almost 60% of boys complete it. So while the gap between girls and boys has narrowed over the years, boys are still lagging. In California, we see similar trend. We see higher vaccination rates in general compared to the national average, with girls achieving almost 89% completion for one dose and 71% for the series. And then boys have completed 84.5% for one dose and 67% for the series. Despite California's higher rates, we're still observing this gender disparity within your state, with boys trailing behind girls in both initiation and completion of HPV vaccine. I will note that there is a lot of really interesting research coming out suggesting that one dose of the HPV vaccine might be as effective as 2 or 3 doses in adolescents under the age of 15. So if eventually we get to that point in the US, then obviously our series completion would look much better because having achieved one dose, you would be at almost 89% in California for girls, which is great, right? Very close to what you're doing for Tdap. So it will be interesting to watch over the next few years what the CDC and ACIP decide to do about moving to a one-dose schedule. All right. So what are some evidence-based strategies for combating misinformation? First of all, trust in healthcare providers. It's one of the most important and effective tools against misinformation. So a study I was a co-investigator on in 2023 confirmed that healthcare professionals are often the most trusted source of vaccine misinformation or vaccine information, for parents. And this trust can be a key factor in overcoming hesitancy. When addressing misinformation, it's crucial to use clear, empathetic language. There was a 2015 study that suggested that acknowledging parents' concerns and providing balanced, clear information can help reduce hesitancy. I like that there is a training that's offered on the announcement approach to HPV vaccine, because I think that that is a great sort of universal way to approach recommending the vaccine. And then when you get pushback is when you sort of move into the acknowledging their concerns and taking an empathetic approach rather than shutting down communication. So other strategies, next slide, for combating misinformation are pre-bunking and debunking. So these are things that we're starting to get into what is used online on social media. There was a study conducted in 2022 that found that accuracy prompts, which is a pre-bunking strategy, effectively reduced the spread of misinformation on social media and showed promise for addressing vaccine misinformation. So accuracy prompts, I don't know if you remember seeing them, but they were like little pop-ups that said, hey, this information might not be factual, and here is a good source for factual information. In a study that we conducted last year, we also found that pre-bunking messages really decreased parents' belief in misinformation and increased their intent to get the HPV vaccine for their children. And we are launching a clinical trial to see if that actually affects behavior. So moving beyond intent to see how does pre-bunking affect parents' vaccination acceptance. Parents often express concerns around vaccine safety, side effects, and long-term impacts. It's very similar across all vaccines. These are the concerns that parents have. A 2021 study conducting a Facebook campaign addressed these concerns and saw a substantial increase in HPV vaccination rates, particularly in lower socioeconomic groups. This study was in Israel, and so it was among moms and daughters. Next. Another useful approach to addressing vaccine hesitancy is motivational interviewing. There has been some studies done on motivational interviewing across lots of different behaviors, but for vaccines, we found that it can significantly improve vaccine uptake, especially when providers use interactive and supportive communication techniques. Next. So there are some common myths that we see repeatedly across social media, and you've probably heard in your practice. And these are that the HPV vaccine might promote sexual activity, and that it's unnecessary. It's unnecessary for boys, or it's unnecessary because their child isn't sexually active. Directly addressing these myths can help shift attitudes, especially when targeting social media misinformation. What I have found is very effective is asking people what their concerns are, what have they heard, what is bothering them about the vaccine, and then where did they hear it? Show me where you saw this, or can I see the post, and that kind of thing. And then you can start to point out things that they might want to consider, like this is not actually a group of children's doctors, but it is an anti-vaccine organization, and here's some information they put out that is definitely not true. And being able to sort of teach people how to look more critically at their sources can help shift their attitudes and beliefs. Next. Visual aids are also great. Several studies have found that using visual tools such as infographics and videos are particularly effective in increasing vaccine adherence, especially among low-income or hard-to-reach populations. So how can we apply all of this? So clinicians or practice administrators can use these strategies by building trusting relationships with families, to dispel misinformation and emphasize the long-term cancer prevention benefits of HPV vaccine. And I'll really emphasize that building a trusting relationship with parents means not barring them from practice if they refuse a vaccine, because what we found is that many parents will change their minds later. So instead, just digging in a little bit to find out what are their beliefs, what are their concerns, giving them some other sources of information, and then reintroducing the topic every time that child comes in. And you will see people change their minds, especially if you approach it in sort of a respectful and empathetic way. Next. So what are we still learning? What don't we know yet? So there's a consensus that clinicians play a crucial role in addressing vaccine hesitancy. However, research directly linking specific clinician interventions to increase vaccination rates is limited. We know that the announcement approach works. There's definitely strong evidence showing that. There is also evidence showing that training clinicians to answer common misinformation questions can be effective, as a second step after making the announcement if parents ask questions. But we lack real-world studies examining the long-term effects of various communication strategies. So, okay. So to bridge the research gaps, we need more real-world longitudinal studies that focus on clinician-patient communication methods. It's also important to evaluate how these interventions work across different populations and settings to ensure that they are broadly effective. And that is the end of my presentation. Thank you so much for listening, and I look forward to any questions you might have.
Thank you so much. That was excellent. I loved seeing all of the visuals too. All right, so let's open it up for questions. I see one in the chat. Is there a list of FAQs with responses to address misinformation that could be shared with providers?
Yes, I believe that the CDC has a list of FAQs, and what I can do is email it to you afterwards, and you can distribute it to the group.
Awesome, great, and I will send that on the list for those who are registered. Thank you.
Perfect. Yeah, I'll make a note so I remember to do it. Right.
I don't see any other questions in the chat. Does anyone have any questions that want to come off mute? Just go ahead and come off mute if you have a question.
I answered all the questions.
This was really great information, and thank you so much for your presentation. I really enjoyed it.
Thank you.
We were speaking recently with one of our pediatricians who's a very strong advocate for HPV vaccination and is most definitely using the announcement approach.
Mhm.
But he did share, and I'm sure, this is not a surprise to anyone. We do see racial disparities in parents' willingness to accept the vaccine, and that for some, it's just he described it as a very deeply held core belief. So just, kind of wondering if you have any strategies to address those obstacles.
Yeah. It is much harder to move people when they have a very strong belief against vaccines in general. It's a little bit easier if it's vaccine specific. So if they are very strongly against the HPV vaccine but have accepted other vaccines for their child, then you know that you might be able to address some of the misinformation that they believe in and move them a little bit in the right direction. So like what I said before, it's really about sort of keeping that door open and revisiting the conversation and trying as much as possible to figure out what's driving these beliefs. What have they heard? Where did they hear it from? Teaching them a little bit about how to critically evaluate sources of information. Sometimes I've had people send me studies and say, is this a real study or not? And I will point out all the places in which it indicates it's a fake study. So, and the anti-vaxxer organizations do produce fake studies, and they do have people that say they are doctors, saying that it is dangerous. So they lie, essentially they lie. There's no other way to put it. And so you just have to be able to teach people to recognize that. For people that are really strongly against vaccines, I don't know, we don't. So that is probably one of the things that we're most lacking on research. We don't really know how to move those people. Sometimes their children getting some of these diseases can move them more towards vaccinating, and it's like an individual practice decision whether or not you want to keep them in your practice and risk, their children bringing in these diseases. So it's a great question.
Hi, thank you for your presentation, Melanie. My name is Jane. I was wondering if you have good examples of pre-bunking on social media, whether it's, pro-vaccine groups that are doing good messaging along those lines, or individuals, or even
Yeah,
toolkits that agencies may have put out.
that's a great question. I have not seen any toolkits, but I will do a search and I'll send it along if I find anything. What we found so far in the study that I'm conducting is that the pre-bunking messages that are effective are actually very simple. So messages that are sort of almost similar to announcement approach messages seem to be effective. So saying that the vaccine is important and it prevents cancer, and also emphasizing that so many adolescents have gotten it and are safe, and that it doesn't have these sort of horrible side effects. You can't say that anything is completely safe. And I wouldn't recommend that you say that. Obviously, there's always risk, but the risk of getting a disease is much greater than the risk from a vaccine. And so if you get into that kind of conversation, that's sort of the approach you would want to take. But yeah, I'll look and see if there's any resources for pre-bunking messages. But again, like the things that the CDC recommends that you say are very similar to what tested well for our pre-bunking strategies.
Okay. I'm just curious, did you do any testing of, or are you familiar with like truth sandwich approach?
Yeah. So we tested a couple of different ways to deliver messages, and straight pre-bunking actually worked as well, if not better, than the message sandwich. So your best bet is probably pre-bunking, but I will caution that it really depends on the audience. So people that are a little bit more firmly held in their beliefs might do better with a different approach, like a message sandwich, like something that you're more directly addressing their concerns. Whereas people that you're just trying to get ahead of it, the pre-bunking announcement style does work very well.
Okay, great. Thank you.
Mhm. Any other questions? Jane, I will ask you, are you looking to like disseminate messages on social media, or is this for clinician practice that you're looking for pre-bunking messages?
I work for the State Department of Public Health, so it would be not so much clinical messaging, unless we were putting together a resource. But I was picturing when I asked the question, yeah, social media messaging.
Okay, great. Yeah, I can definitely send along what I found, some good resources for you.
I would really appreciate that. Thank you.
Mm.
Any other questions for Melanie? Okay. I don't see any more in the chat, and I haven't heard anyone else come off mute. So here is our dates in 2025. We're going to be continuing our collaborative sessions January, April, July, October. And we want to thank everybody for joining us today. You can learn more about the work of the Roundtable by visiting our website. And you can send any questions through our email at info@chpvroundtable.org. And I have also included the evaluation link in the chat. If you can help us by evaluating the session, that would be great. But I want to thank our guest speaker, Melanie, again, and everyone else for joining us today, taking time from your lunch hour. If you yourself have any best practices you want to share for HPV vaccination, please let us know. Or if you have any recommendations for us, please contact us and let us know. Other than that, I want to thank you all again, and I'll see you all next year.
Thank you. I enjoyed being here. Thank you so much.
Thank you.
Thank you.